Okay, what's up, guys? Welcome back. This is going to be another in the series of practice questions for studying for the Pance. This is going to be the pulmonary section, so we'll go ahead and get started. We'll start with lung sounds here. So which lung sounds, it's important to know what lung sounds they're describing. So high-pitched sounds heard during auscultation upon inspiration due to popping open of the collapsed alveoli in small airways, typically from fluid or exudates like pneumonia, and transudates like heart failure. What would that be called? This high-pitched popping open of the collapsed alveoli. What is that? What is that called? How about sounds heard loudest over the anterior neck that are due to narrowing of the trachea or the larynx? What would that be called? Over the anterior neck. How about a whistling sound that's continuous and musical in nature that is usually louder during expiration compared to inspiration and is produced by narrowing or obstruction of the airways? So again, louder during expiration as opposed to inspiration. So first one, that's crackles or rails. So you always want to think if you have transudates like heart failure, the most common cause of a transudative, then you want to be thinking crackles or rails. Stridor, over the anterior neck, you want to be thinking of stridor, such as in croup, for instance. So stridor. And wheezing. So wheezing is kind of described as whistling or continuous musical sound, and that's louder during expiration compared to inspiration. You can think of asthma for something like that. Okay, next one is a 31-year-old patient. A 31-year-old patient comes in with chronic productive cough and denies a history of smoking. You get a chest x-ray and you notice a flattened diaphragm and a barrel chest and an increased AP diameter. The patient says they have been getting worse for years. What are you suspecting? So again, most important, no smoking history, 31-year-old patient, flattened diaphragm, barrel chest, increased AP diameter. What is this? What segment, be it proximal, distal, or diffuse, of the lung would you expect to be affected in this condition? So where would you expect to be affected in this condition here? So that's going to be alpha-1 antitrypsin deficiency. So it's not COPD, or it is COPD as a result of alpha-1 antitrypsin because think about it, it's a young person, so they have no history of smoking, which is the leading risk factor for COPD. And they have COPD findings, however, on that chest x-ray. So that's alpha-1 antitrypsin deficiency, and you'd expect diffuse. The area affected in the lungs would be diffuse because it's a problem with the liver producing alpha-1 antitrypsin. So that's going to affect everywhere, whereas it would just affect proximal if it was due to smoking in COPD because that's where the smoke hits when it first comes into the lung. So diffuse in COPD caused by alpha-1 antitrypsin and proximal in COPD caused by smoking. So next one is a 67-year-old male with a 25-pack year of smoking that has progressive cough for years. You tell him this is an irreversible airway obstruction. What is the diagnosis? So again, 25-pack years, 67-year-old male, irreversible airway obstruction. What is that? What is it if the pathophysiology is a loss of elastic recoil that is progressively declining? So again, a loss of elastic recoil, what specific thing is that? What if it is the pathophysiology of intermittent exacerbations of increased airway resistance in this patient? So two different pathophysiologic mechanisms here. Which one is which in relation to the disease that this 67-year-old male has? So that's going to be COPD, of course. This male has COPD. The first one is emphysema. So that loss of elastic recoil, you want to be thinking of emphysema, loss of elastic recoil. Chronic bronchitis, that's going to be the intermittent exacerbations of increased airway resistance due to that mucus buildup or mucus plug in these patients. Okay, so next one's going to be some matching. I've been liking this format recently with the matching with disorders that are similar that they often ask you to differentiate between. So you're going to need to know or be able to differentiate between emphysema versus chronic bronchitis, even though in real life they typically would have both of these or any of them, and it's more mixed together. But for testing purposes, you need to know the difference between emphysema and chronic bronchitis based on the vignette that they give you. So first one, which one has a matched VQ defect? A matched VQ defect, ventilation perfusion defect. How about one with alveolar capillary destruction? So which one is more alveolar capillary destruction? Which one, chronic bronchitis or emphysema, has a respiratory acidosis more commonly? How about a decreased DLCO or a diffusion capacity of carbon dioxide? Decreased DLCO. Which one would have bullae? Which one would have an increased H&H, hemoglobin and hematocrit? Which one would be more chronic cough with sputum as the common symptom? Again, chronic cough with sputum, which one? Which one would have a severe ventilation perfusion mismatch as opposed to a matched ventilation perfusion defect? Which one is dyspnea, the most common symptom? Which one is dyspnea, the most common symptom? Which one would have hyperresonance to percussion? Hyperresonance to percussion. Which one is called a pink puffer? Which one's going to be more hypercapnic? Which one's a blue bloater? Which one's more associated with multifocal atrial tachycardia? So again, multifocal atrial tachycardia, which one? Which one's more associated with spontaneous pneumothorax? That would also have those bulla. And which one is leading to cor pulmonale more commonly? Cor pulmonale. Which one is increased residual volume and total lung capacity? Which one would have pursed lip breathing to exhale? So they're doing this pursed lip breathing in order to exhale. Defined as productive cough for 3 months in a row per year for 2 consecutive years. What is that? And which one is more common to have Haemophilus influenza growing? Now we'll go over the answers. So the one with a matched VQ defect, that's going to be emphysema. So matched VQ defect, the whole idea in emphysema is we can get air in, but we've lost that elastic recoil to push the air out. So we're still getting oxygenated air in, and so that's why we have a matched VQ defect. Next one, alveolar capillary destruction. Like we just said, that's emphysema, a loss of the elastic recoil, making those alveoli more like bags, losing that surface tension in them. So that's alveolar capillary destruction in emphysema. And respiratory acidosis is more common in chronic bronchitis because we're not being able to get rid of that CO2. So we're having the respiratory acidosis, that acid builds up. Decreased DLCO, that's emphysema. Belay, that's emphysema, which could lead to that secondary spontaneous pneumothorax. Belay for emphysema. Increased H&H, chronic bronchitis. We're going to be hypoxic, having the kidneys stimulate erythropoietin, increasing that hemoglobin and hematocrit overall. So we're going to have that in chronic bronchitis. Chronic cough with sputum, chronic bronchitis. Severe VQ mismatch, chronic bronchitis. Dyspnea is the most common symptom. That's going to be emphysema. Hyperresonance to percussion, emphysema. So a lot of air trapping going on in emphysema as we're not able to really exhale all that air out. So again, hyperresonance in emphysema. Pink puffer is classically emphysema as well. Hypercapnic, that's going to be chronic bronchitis. Blue bloater, chronic bronchitis. Multifocal atrial tachycardia associated, chronic bronchitis again. Chronic bronchitis causes a lot of right heart strain, and so that could be what's leading to that multifocal atrial tachycardia. Spontaneous pneumothorax, emphysema, because we said those bulla can rupture, and that's more common in emphysema. Cor pulmonale, that's chronic bronchitis, like we said, heart failure due to a primary pulmonary condition, cor pulmonale, chronic bronchitis. Increased residual volume and total lung capacity, emphysema. Pursed lip breathing in order to exhale, emphysema. Defined as productive cough for 3 months per year for 2 consecutive years, chronic bronchitis. And H. flu, most commonly grown in chronic bronchitis as well. Remember, those mucus plugs can harbor a lot of bacteria. Okay, next one. What is the classic finding for both forms of COPD found on the best test for diagnosis? So what is the best test basically, and what are we going to find on that test? What is the most important first step for a patient with COPD? What is the most important for mortality benefit? And it's also a clue is directly proportional to the time using this substance. And what criteria is used to classify COPD severity? So this is going to be a decreased FEV, forced expiratory volume in 1 second. So how much they can exhale in 1 second. It's going to be decreased because this is a obstructive condition. So decreased FEV1 in COPD. Also a decreased FEV1 to FVC, forced vital capacity ratio, under 70%. Smoking cessation is the most important initial step, and oxygen home therapy is the most important for mortality benefit. And when do we give oxygen home therapy? We want to worry about the oxygen drive in these patients, so we only give it to them when they're below 88% oxygen saturation or below a PaO2 of 55 millimeters of mercury. So those are the 2 indications for when we give it in COPD for home therapy. And that criteria used to classify COPD, that's going to be the GOLD criteria, it can also help us in how we're going to treat COPD as well. So next one, a patient with long-term COPD comes in already on a SAMA, ipratropium, short-acting muscarinic antagonist, ipratropium, the first-line agent, and is having more exacerbations. So SAMA, that first-line agent, they're using that already. They have long-term COPD, and now they're having more exacerbations. What do you want to add next? So they have COPD, they're already on a SAMA. What's your next medication that you're going to add? What are the side effects of a SAMA or a LAMA, long-acting muscarinic antagonist, which is tiotropium? So how to remember quickly, SAMA is ipratropium. SAMA comes first. It's short-acting, and it has an I, so it comes first in the alphabet. Tiotropium has a T, comes later in the alphabet, and it's longer-acting. That's a LAMA. Next question is, what med might we add after a SAMA and SABA and a LAMA and a LABA are added if symptoms continue? So basically, we've done everything we can, and then what medication are we going to add? Okay, so after that first one, after we added that SAMA, the ipratropium, we could add a LAMA, tiotropium, or a LABA, formoterol or salmeterol. So LABAs are formoterol, salmeterol. Typically in COPD, the LAMAs and SAMAs, the muscarinic antagonists, are going to be better than the long-acting and short-acting beta agonists. So we could add a LAMA or a LABA after that short-acting. Anticholinergic side effects are what we'll find, of course, such as anti-sludge, so anti-salivation, lacrimation, urination, defecation, GI, and emphasis. So we're going to have opposite of that. And at this point, we could add fluticasone, an inhaled corticosteroid, which is not first line. So we only add the inhaled corticosteroid, which is typically second in the treatment of asthma after the SABA, but in COPD, it's much later. So we would do that as the last thing. So next, we'll go through obstructive versus restrictive. So not only what is the difference, but what conditions are obstructive or restrictive, it's important to know. Okay, so which one is obstructive versus restrictive? Co-workers pneumoconiosis, is that obstructive or restrictive? How about other pneumoconioses? So it's co-workers, and every other pneumoconiosis is another type, either obstructive or restrictive. Which one, obstructive or restrictive, has an increased total lung capacity? Increased total lung capacity, so more is in the lung. Decreased residual volume. Which one has a decreased residual volume left over in the lung? Normal or increased FEV1 to FVC. So which one is going to be normal or increased FEV1 to FVC? Asthma is what? Obstructive or restrictive? COPD is what? Myasthenia gravis is what? Scoliosis leads to what? Bronchiectasis is what? Sarcoidosis is what? Obstructive or restrictive? How about if they have a decreased FEV1 to FVC? What's that going to be? And which one is marked by decreased lung volumes overall? So those are the questions there. So the answers here, co-workers pneumoconiosis, that's the only pneumoconiosis that's obstructive. All the other ones are restrictive. So all the other pneumoconioses are restrictive. They typically cause a restrictive pattern, except for the co-workers or black lung. That's obstructive. In increased total lung capacity, that's of course obstructive, because the obstruction is going out and we have a lot of increased air in the lungs. Total lung capacity is increased in obstructive condition. Decreased residual volume in restrictive, because the lungs need every ounce of air that they're getting in. So there's going to be much less left over because there's less space inside the chest cavity anyways, inside the lungs that the lungs can use. So restrictive for a decreased residual volume left over. Which would have a normal or increased FEV1 to FVC? That's going to be restrictive. So they're able to blow the air out, it's just they have a restrictive amount of air in the lungs. So they can blow the air out, but they just have a restrictive amount. So the FEV1, the forced expiratory volume in 1 second, is going to be okay. They're not having a problem with that. It's not obstructive. Asthma is obstructive, of course. COPD is obstructive, of course. Myasthenia gravis is restrictive because we're not having the ability to really contract that diaphragm as we should be able to. It gets tired and it's not able to contract, which would pull more air into the chest cavity. So therefore, it's a restrictive pattern. We have less lung room to deal with. Scoliosis, same thing, also restrictive. Think about if the chest cavity is smaller because of the way the spine is curved. You want to be thinking of that for scoliosis. That's a restrictive pattern. Bronchiectasis is obstructive, similar to COPD. There's mucus plugs and a lot of obstruction in bronchiectasis on the way out. So obstructive. Sarcoidosis, restrictive. Decreased FEV1 to FVC is, like we said, obstructive. They're not able to get that out. The forced expiratory volume in 1 second has been decreased. Marked by a decreased lung volume overall, as we explained, restrictive. Okay, so next one. A 7-year-old comes in with a fever and cough for 4 days. You start antibiotics after getting a chest x-ray. The patient states that this is their 6th episode in the past year, and they also have steatorrhea. What is the diagnosis? So again, a 7-year-old, repeated episodes, 6 in a year, and they also have steatorrhea. What is that indicating for you? What is the classic finding on chest x-ray of these patients? What is the classic finding? What is the best test of choice in order to diagnose what this kid might have? What is the pathophysiology of this condition? And what is the most common bacteria that accompanies this diagnosis? So important to know what bacteria is most common in this diagnosis. So this is going to be, of course, cystic fibrosis. On x-ray, they'll have bronchiectasis that shows a tram track appearance. So it's important to know tram track appearance with air bronchograms. So that's bronchiectasis and cystic fibrosis. There's also a Signet ring sign, which is classic. So the classic signs for bronchiectasis and cystic fibrosis are, again, tram track appearance, air bronchograms, and Signet ring sign. You want to do a sweat chloride test for the diagnosis of cystic fibrosis, which is most accurate, and you could administer pilocarpine, which induces the sweating. So you should see over 60. That's diagnostic for cystic fibrosis. Sometimes they'll give you a number that's below 60, and you need to know that 60 is actually the cutoff, so above 60 is going to be diagnostic, and that's for that sweat chloride test. The pathophysiology is a mutation in the cystic fibrosis transmembrane reductase, I believe, or receptor that leads to abnormal chloride and water transport across the endocrine glands in the body, leading to a pink viscous secretions and thick viscous secretions in the lungs, pancreas, and sinuses. So that's why we had steatorrhea and why we need to supplement in patients with cystic fibrosis for vitamins A, D, and K, because they're fat soluble. So if we're having thick viscous secretions in the pancreas, then lipase and other enzymes are not being secreted. So therefore we can't break those things down. Therefore we have steatorrhea. And therefore we also can't absorb the fat soluble vitamins A, D, E, and K. And the most common bacteria that we have to think about here is Pseudomonas. So Pseudomonas is common in cystic fibrosis with bronchiectasis. Next one is a 3-year-old that comes in complaining of a cough that started last night after being exposed to the cold air. They have no fever, retractions, or wheezing that's noted, but his mom insists this has been happening occasionally with worse exacerbations every so often, but they have never been in to see it, to be seen for it. You also note a pale blue turbinate and a crease over the nasal bridge and cobblestoning when everting the eyelid. What are you thinking of, and what is the diagnostic tool you can use? So again, some signs: 3 years old, exacerbation after having cold air exposure, pale blue turbinates, a crease over the nasal bridge, cobblestoning when everting the eyelids. What do you think this is? What immunoglobulin will be elevated in this condition? What 2 substances can we use to make this diagnosis? And what percentages are we looking for? So in order to make an official diagnosis, we have to do 2 things. And what are the percentages that we're looking for, and what do those things do? Okay, so this is going to be asthma. Pulmonary function tests are how we make the diagnosis. It's IgE mediated, so that's mast cell stimulation and increased leukotrienes. We want to do for diagnosis bronchoprovocation challenge tests. So first with methacholine, which is a parasympathetic agonist, so methacholine. So that will constrict it down. It will decrease the openness of the bronchioles. So therefore, we're going to have constriction. So we should see a marked decrease, over 20%, in these patients that have been provoked with methylcholine challenge test. So we should see a 20% decrease in these patients. And then we try to fix it with albuterol. So it is diagnostic for asthma if they actually increase by 12% after administering the albuterol after doing the methylcholine challenge test. And that's 12%. So we'll also see overall a decreased FEV1 because it's an obstructive pattern, as we said asthma is. And it's a reversible obstruction, however. So again, the important things to know, first, methacholine for diagnosis, over 20% decrease, and then fix it with albuterol, over 12% increase as it opens the lungs back up. Okay, next one, a few more questions about that. What is the atopic triad? So it's important to know what the atopic triad is. What is the Samter's triad? So these are the questions of triads, I guess. Atopic triad, Samter's triad. What are the three components of the pathophysiology of asthma? So 3 components. What is the triad of symptoms in asthma, the 3 most common symptoms? And how do we assess exacerbation severity? So there's a specific tool that we can use for asthma to assess exacerbation severity. What is that? So again, atopic triad, Samter's triad, 3 components of the pathophys of asthma, triad of symptoms for asthma. How do we assess exacerbation severity? So this is going to be for atopic triad, allergic rhinitis, atopic dermatitis or eczema, and asthma. For Samter's triad, SA, Samter's triad, this is going to be AS, asthma, AS, aspirin, and AS, nasal polyps. So that's how I remember it. Samter's triad has SA, and all of the things in Samter's triad have AS, again, asthma, aspirin sensitivity, and nasal polyps. The 3 components of the pathophys of asthma are airway hyperreactivity, bronchoconstriction, and inflammation. So airway hyperreactivity, bronchoconstriction, and inflammation. The triad of symptoms are going to be dyspnea, wheezing, and cough, especially at night, and especially exposed to cold air. And we can do for assessing the exacerbation severity, peak expiratory flow rate. Peak expiratory flow rate. So we need over 70% to discharge after an exacerbation of asthma. So we need over 70% to discharge them, whether they came from the hospital or whatever, after an asthma exacerbation. So next one, what would you want to use for an acute asthma exacerbation? And what are the side effects if you have a patient that is really going overboard with it? So some people are just really using this first line for acute asthma exacerbation medication a lot. So what would you expect that they're going to have as symptoms as side effect? And what does it do to in terms of receptors? So what receptors are actually going on here when they're using this first line medication? So I'll explain that a little bit. Important to know as well. And also, what acid-base disturbance might we see in an asthma exacerbation? Well, let's say in an early asthma exacerbation as well, because a late exacerbation might be something different. So that's going to be a short-acting beta-2 agonist. Short-acting beta-2 agonists like albuterol. We get the side effects of cardiac because both beta-1 cross-reactivity is occurring, such as tachycardia, palpitations, and remember, beta-1 is your BEAM beta blockers, and those go right to the heart. So beta-1 has to do specifically with the heart. So if we have cross-reactivity from the SABA, we're going to have cardiac symptoms like tachycardia, palpitations, nervousness, sweating, tremors, CNS stimulation, and also remember hypokalemia. Remember, albuterol can be used in hyperkalemia a little bit to shift that potassium into the cell a bit. So don't forget hypokalemia when they're overusing those short-acting beta agonists. And we might also see a respiratory alkalosis because they're hyperventilating, they're blowing off a lot of CO2 that makes their overall pool acid-base disturbance a little bit more alkalotic due to those respirations. However, in a late asthma exacerbation, when they're already tired of breathing, we may start to see a respiratory acidosis as they start to retain more CO2 because they can't breathe as much, or if it gets to the point where it's a silent chest, that's even worse. That's definitely a respiratory acidosis. Next one, a patient comes in with a mild asthma exacerbation. You handle it mainly with albuterol and discharge them with a short course of prednisone. What side effects should you educate them on? So they have a short course of prednisone now. What do you want to educate them on this prednisone might do? What is a side effect of an inhaled corticosteroid if used incorrectly? So again, this short course of prednisone, that's going to be orally. But what side effect of inhaled corticosteroid if used incorrectly? There's one main one. What medication should you step up to after symptoms are not controlled with an ICS? So you used your SABA, it's not controlled. You used your ICS, it's not controlled. Now what? Okay, so immunocompromised, you want to educate them that if they are immunocompromised, this is going to be a risk for infection. Hyperglycemia, steroids can increase your glucose. Fluid retention, importantly, with steroids. And osteoporosis if used long-term. Inhaled corticosteroids, this main side effect is using the spacer correctly. So if they don't use it correctly, it's going to get stuck in the throat and could lead to oral candidiasis. So, and also in a note, I know we talked about in the GI section, but remember that we treat eosinophilic esophagitis without a spacer because we actually want that to get there. So eosinophilic esophagitis, we actually want the steroid to get inside the esophagus. So that's why we don't use a spacer in that case. And we should wash their mouth out after so that we can hopefully avoid this oral candidiasis in the inhaled corticosteroids. And so after this, after we did the SABA, after we did the inhaled corticosteroid, the next step is a LABA, long-acting beta agonist, again, formoterol or salmeterol. And it can be added but not used alone. So we never use a LABA alone, always with an ICS. Okay, next one. What medication for asthma is used for cold air and exercise prophylaxis only that takes a couple weeks to start working? So after a couple weeks, it starts helping you with cold air and exercise prophylaxis. What medication specifically for that for asthma? What medication is similar in structure to caffeine, has a narrow therapeutic window, and higher levels are needed in smokers? So again, similar structure to caffeine, narrow therapeutic window, higher levels are needed in smokers. What medication is that? So these are two different medications here. So that's going to be the first one for the cold air and exercise prophylaxis, but it takes a couple weeks. That's going to be mast cell modifier like cromolyn or nitochromyl. And the caffeine one is going to be theophylline, which is a methylxanthine. So methylxanthine is the structure, and that's similar to caffeine, and that's going to be theophylline. Again, now a therapeutic window, higher levels are needed in smokers. Those are the two important things that we should know about theophylline. Next one is a 5-year-old that comes in, and his mother states that he has, for the past month, been having nighttime awakenings due to asthma 9 times in the past month. Again, 9 times, and some daytime symptoms as well. She states that he uses his short-acting beta agonist and low-dose ICS to no avail. You measure his forced expiratory volume in 1 second, and it's 75% of the predicted value. So again, the highlighting points. 5 years old, nighttime awakenings 9 times in the past month. Daytime symptoms, already he's on a SABA, already he's on an ICS low dose. FEV of 75%. What stage of asthma is this? So they often ask questions like this and expect you to just know what stage it is. What med might you want to add? So again, already on a SABA, already on an ICS. What do you want to add? What stage of asthma is this? This is moderate persistent. So again, moderate persistent asthma, over 8 times awakening from sleep per month. So over 1 times per week. Not 1 time and over, but over 1 time per week. So 2 or more. So it must be at least 2 per week, like we said. And daily symptoms not controlled. So you want to add that long-acting beta agonist, formoterol, salmeterol, to that ICS, keeping the ICS there, or increase the ICS dose. So in moderate persistent, we can do 2 things. We can either increase the ICS from a low dose to a higher dose, or we can just add a LABA and keep it low dose. But again, that moderate persistent is at least 2 episodes per week of nighttime awakening. So that's moderate persistent. Next one is a similar question. A patient comes in that is having 3 nighttime awakenings per month. So 3 nighttime awakenings per month, less than 1 per week, due to exacerbations. She's only on a SABA. She states that there is only mild impairment of daily activities with the FEV1 predicted at 80%. What stage is this, and what med do you want to add? So what stage is this? She's having 3 nighttime awakenings per month, and she's only on a SABA. And again, the FEV1 is 80%. What do you want to add? And what stage, of course? So this one is going to be mild persistent. So mild persistent obviously comes before moderate persistent, and you can add an ICS. So what's your next step after a SABA? ICS. Why is it mild persistent? Because we haven't hit the 2 times, we haven't even hit 1 time per month of nighttime awakenings yet, but it's still more than once per month. So 3 nighttime awakenings per month. That's going to be mild persistent. Next one, a patient comes in with nighttime awakenings every night, and they are maxed out on a LABA, formoterol and salmeterol, and an ICS and a SABA. Her FEV1 is 55% of the predicted value. What stage and what do you want to add? So this one's more obvious. This is, of course, severe persistent. If they're having nighttime awakenings every night and they're already maxed out on all these meds, then of course that is severe persistent. We can add Omalizumab, possibly, and also a pulmonary referral. So omalizumab, we could add possibly. Okay, next one. Next one is a 35-year-old African American that comes in with complaints of cough that is non-productive. There's shortness of breath, and you also note some rales on auscultation. You notice some odd erythematous nodules on her shins and a rash on her face. Otherwise, the physical exam is normal. What condition are you suspecting? So again, important things, 35 years old, African American, and also female. Some nonspecific respiratory complaints, some odd erythematous nodules on her shins, and also importantly, a rash on her face. What is this? What is this rash specifically called that's on her face? What are the shin findings called? Something specific. What is Lofgren syndrome a triad of? So another triad here, Lofgren syndrome. So this is going to be sarcoidosis. So sarcoidosis is importantly middle-aged African-American females, most commonly for sarcoidosis. Lupus pernio is the rash on the face, lupus pernio. Erythema nodosum is on the shins, those nodes that are erythematous on the shins. Erythema nodosum, like we said, bilateral hilar lymphadenopathy and polyarthralgias with fever. That's going to be Lofgren syndrome, Lofgren triad there. So again, Lofgren triad, erythema nodosum, bilateral hilar lymphadenopathy, and polyarthralgias with fever that are notable in sarcoidosis. Next one, what will you find on tissue biopsy in sarcoidosis? So this is an important thing, and it's not what you would find in TB. So the opposite of what you'd find in TB on tissue biopsy of sarcoidosis. How about specific lab sign that is elevated? So it's important to know this one. What is a specific lab sign that is elevated in sarcoidosis? And what will PFTs show? We already said what sarcoidosis was, but we'll see if we remember here. What will PFTs show? And what is the first-line treatment? So what is the first-line treatment for sarcoidosis? Biopsy will show non-caseating granulomas. So again, TB is caseating granulomas, right? So non-caseating granulomas, the opposite in sarcoidosis, and that's on biopsy. ACE is increased. Angiotensin-converting enzyme is increased in sarcoidosis, interestingly. It's a restrictive pattern, as we said before. Oral corticosteroids are the treatment. And again, don't forget classic bilateral hilar lymphadenopathy. So that's like the most bolded thing that you could remember out of this. Don't forget classic bilateral hilar lymphadenopathy. And like we said, African-American and middle-aged females. Next one is an older gentleman that comes in and complains of progressive shortness of breath for some time now. He has no smoking history, no other past medical history. He comes to you for a second opinion after being told his condition is hopeless and only a lung transplant will help him. What diagnosis would you consider? So basically, he needs a lung transplant. He was told it was hopeless by another person. He wants a second opinion. No smoking history, older man. What is the classic chest x-ray and chest CT finding? So there's a couple findings here that we have to know. Classic chest x-ray and chest CT finding. What two meds do not help mortality but can be used as antifibrotics? So that kind of gives it away. What two meds do not help mortality but can be used as antifibrotics? So this is going to be idiopathic pulmonary fibrosis. So again, think old man, no history of smoking, progressive shortness of breath. Lung transplant is definitive, but you can use pirfenidone and nintedanib. So pirfenidone and nintedanib are antifibrotics, but they don't necessarily help mortality. Only a lung transplant is definitive for these patients. And importantly, the most important finding, they might just say, what do they have? Chest x-ray and CT findings will show honeycombing. Honeycombing on chest x-ray and CT, reticular opacities, and a focal fine ground glass appearance and opacification. So again, honeycombing with reticular opacities and a focal fine ground glass appearance and opacification. Okay, next one. A quarry worker comes in with a cough that is dry. You notice on chest x-ray there's eggshell calcifications and upper lobe involvement. What is the diagnosis? So some of these you just have to know where they're working and where the involvement is. So that one's upper lobe and they're a quarry worker and they have the classic eggshell calcifications. What is the diagnosis? Next one, keep that one in mind. So next one is a patient that has black lung on biopsy and you find upper lobe involvement with small nodules and a hyperinflation in an obstructive pattern. interestingly, because we already talked about an obstructive pattern. What is this? And also, what is Kaplan syndrome? So what is Kaplan syndrome? So this is going to be silicosis. The first one is silicosis. So you want to be thinking of those quarry workers. And quarry is in the ground. So you want to be thinking of the upper lobe involvement because it's the opposite. So if they're working in the ground, if the occupation is something to do with the ground, then you want to be thinking upper lobe involvement. Same thing with the second one, which is coal workers pneumoconiosis. They work in the ground and they have upper lobe involvement. So again, silicosis, quarry work, upper lobe involvement. Coal workers was the second one, pneumoconiosis, upper lobe involvement. And we also said coal workers pneumoconiosis was the only one that was an obstructive pattern, whereas the other pneumoconioses were a restrictive pattern. And what is Kaplan syndrome? Kaplan syndrome is just coal workers pneumoconiosis plus rheumatoid arthritis. So if they have RA and coal workers pneumoconiosis, you want to be thinking of Kaplan syndrome. Next one, to continue on, aerospace and electronic engineer. An aerospace and electronic engineer now has shortness of breath. What are you considering? So all you're given here is the job that they have. Aerospace and electronic engineer has shortness of breath. Next one, someone from a textile factory has now been exposed to cotton, comes in with a cough. What are you thinking? It's worse at the end of the week and a little bit better on Monday. What are you thinking? So the first one is berylliosis. So berylliosis, beryllium. So I guess if you're working in like nuclear power plants or aerospace and electronic engineering, you're exposed to beryllium and you can have berylliosis. Next one is bissinosis, so cotton exposure. So cotton exposure in textile factories, you want to be thinking of bissinosis. Okay, next one, a patient comes in with an occupational history of home and ship renovation. So he used to do home and ship renovation. He also endorses a 42 pack year of smoking. What are you considering? So again, long history of smoking, home and ship renovation. What might you see on chest x-ray that is classic? So in this patient here, what are you going to see on chest x-ray? How about on biopsy? And what two complications is this patient at risk for? So what two complications? And again, this patient has an occupational exposure to home and ship renovation and 42 pack years of smoking. Okay. So this is asbestosis. You're going to see on chest x-ray very classically pleural plaques and lower lobe involvement. So think about it. Asbestos is in like shipbuilding as well as insulation for homes, and that's usually in the ceiling or in the walls, but you can think about ceiling. And so therefore, if they're working up high in the ceiling, then they're going to have that lower lobe involvement. So again, asbestosis, pleural plaques, lower lobe involvement. And classically, we see that shaggy heart sign. So shaggy heart sign, which is an indistinct heart border. Biopsy will show linear asbestos bodies, which are also called ferruginous bodies, that will have a restrictive pattern. So important to know, restrictive pattern, ferruginous bodies, biopsy shows linear asbestos. Complications are mesothelioma of the pleura, most specifically, and bronchogenic carcinoma most commonly. So if they have mesothelioma, and you also want to be thinking that asbestos exposure and a long history of smoking are synergistic to the development of mesothelioma, and that's a cancer of the pleura. So again, what we see on this chest x-ray is pleural plaques, and again, lower lobe involvement. Okay, next one. A patient has been exposed to nitrogen gas released from plant matter for years. He now has shortness of breath and cough. What is this? So again, nitrogen gas released from plant matter for years. A patient with a parrot as a pet for years now has some respiratory symptoms. What is this? So has a bird as a pet, now has respiratory symptoms. What causes this and what is the treatment? So what causes this one and also what is the treatment? So the first one is going to be Silo-Filler's disease. So Silo-Filler's disease you want to associate with nitrogen gas in plant matter, Silo-Filler's. The next one is parrot fever, Piscatosis. It's caused by Chlamydophila piscati due to contact with infected birds. You want to treat like any other chlamydial infection, tetracyclines. So it's important to know if they do have, they might just come out and ask you the treatment, not even what it is. So they might just tell you that this patient has a pet and now he has a pet bird and now he has respiratory symptoms. What do you want to treat him with? Just go right to the tetracyclines or doxycycline. It is chlamydia after all. Next one is a 35-year-old previously healthy patient that comes in with myalgias and fever for 3 days, They state they're overall very tired and also have headaches. They ask if there's any medication they can take for this condition that would shorten the duration of symptoms. What would you say? So again, 35-year-old, previously healthy, 3 days of these myalgias and fever and also headaches. What do you want to say when he asks you what can he take for medication specifically? Who should receive chemoprophylaxis for this condition? So what type of patient population would receive chemoprophylaxis? So you would say if the symptoms arise under 48 hours, under 2 days, you can use a neuraminidase inhibitor, which is oseltamivir, which would help decrease the duration and severity of symptoms. But at this point, in 72 hours out, in a previously healthy male, 32 years old, it would be unlikely to make any difference as she's otherwise healthy. So again, under 48 hours or 2 days, you want to use that neuraminidase inhibitor, oseltamivir. Those in nursing homes or long-term care, when it's flu season and there's an outbreak, should receive chemoprophylaxis with oseltamivir. So again, those in nursing homes or long-term care, when it is a flu outbreak and it's flu season, you want to be thinking of chemoprophylaxis with oseltamivir. And a few questions on the flu vaccine. So sometimes they'll give you some questions on a flu vaccine, and we should know, do we want to give them the regular, the inactivated, or the live attenuated? So here, who should get the flu vaccine? Would it be no flu vaccine? Would it be the inactivated? Or would it be the live attenuated? So what would we give to a 4-month-old? So a 4-month-old patient comes in, mom asks you, does he get the flu vaccine? What are you going to say? None, inactivated, or live attenuated in a 4-month-old. How about in an immunocompromised 66-year-old? What are they going to get if they're immunocompromised and 66 years old? What if they're a 32-year-old and they're also pregnant? How about a 32-year-old pregnant patient? What are they going to get? How about an 8-month-old? So mom asks you, can he get it now? He's 8 months old. What are you going to give him? How about a 5-year-old? How about a 20-year-old who has had GBS, Guillain-Barré syndrome, but never had any vaccine before? So they just had Guillain-Barré syndrome, but they never had a vaccine before that would potentially predispose them to this. Okay, so the 4-month-old, no, we don't give it to them. It's 6 months to 50 years for the live. So no flu vaccine if you're 4 months old, nothing before 6 months. The 66-year-old, that's immunocompromised, yes, we do that, but we give the inactivated. So we think that maybe their body can't handle the activated, so we give inactivated to a 66-year-old immunocompromised patient. 32 and pregnant, again, inactivated. We don't give activated live vaccines to pregnant patients. So she's 32 and pregnant, give her the inactivated flu vaccine. 5-year-old, yes, live vaccine. So now they're at the point where they can have the live vaccine. 20 years old with a previous GBS, but never vaccinated. Therefore, it would be a yes, because it's only if GBS is occurring under 6 weeks after the last vaccine. So it's only if they had a previous GBS in response to a vaccine, and that was under 6 weeks after the last vaccine. Okay, next one is, what are the 2 most common causes of hemoptysis? What are the 2 most common causes of hemoptysis? What is the most common cause of acute bronchitis? So 2 most common causes of hemoptysis, most common cause of acute bronchitis. So that's going to be acute bronchitis and bronchogenic carcinoma are the 2 most common causes of hemoptysis. Again, acute bronchitis and bronchogenic carcinoma, so lung cancer. Viral is the most common cause, of course. Adenovirus, parainfluenza, influenza as well. And we'll do one more question for this section. A 9-month-old comes in and his mom states there has been a violent coughing episode that comes and goes for about 2 weeks now. And she seems scared as he occasionally vomits after the episode. She states he seems to appear to take a deep breath in after the cough and makes a loud sound. What is this? So again, 9 months old, violent coughing episodes, 2 weeks already, vomiting after the episode, deep breath in after the cough that makes a loud sound. What is this? What are the 3 stages of this condition, which might give it away? What are the 3 stages of this condition? What is the best treatment? What medication are we going to give them? When do we normally give the, which gives it away, Dtap vaccine? So when do we give the Dtap vaccine? So of course it's Bordetella pertussis or whooping cough. So this is pertussis, whooping cough by Bordetella pertussis. It's an inspiratory whoop, post-tussive emesis as well are characteristic findings, which we saw in this patient. How to remember it is, how to remember the 3 stages. We said, what are the 3 stages? How to remember it is CPC. It's the catarrhal, the paroxysmal, and then the convalescent phase. So the catarrhal is the first 1 to 2 weeks, and it's the most contagious. That's what this kid was in. And then there's the paroxysmal, 2 to 4 weeks, and they're also having classic symptoms. So this kid had it for 2 weeks, then he's starting to have those classic symptoms of the inspiratory whoop, the post-tussive emesis, and that's that paroxysmal stage, classic symptoms in this stage. Then we finish up with the convalescent phase, which is resolution up to another few weeks. Macrolides like azithromycin are the treatment of choice. And when do we give the Dtap vaccine? It's important to know. Sometimes they ask questions on specifically an age of a kid and what vaccine do you want to give them at this age. So Dtap is a good one to remember. Dtap is 2, 4, and 6 months, and between 15 to 18 months, and again at 4 to 6 years. So again, 2, 4, 6, 15 to 18, 4 to 6 years. Okay, we'll continue along in the next episode for respiratory questions, and we'll leave it at that.